we can start with Janine. The facilitator would be
Me.
Dr. Ruiz would be the facilitator for this discussion. Janine, are you already
Yes,
there?
Doc. Yes, Doc. Good morning po.
Okay,
Dr. Okay.
let's go.
Good morning, doctors. So for the salient features, our patient is a 56-year-old male, um, which has been having a vague right upper quadrant pain for duration of 3 months, accompanied by low-grade fever and unintentional weight loss. Our patient consulted at the local clinic where an ultrasound of his liver was done, showing 6 by 7 centimeters solid mass in the right lobe. For the past medical history, our patient had pulmonary TB in 2000, which was adequately treated for 6 months. He also had jaundice when he was in college, for which he was told to have acute viral hepatitis. For the family history, um, his mother, uh, his mother died of hepatocellular carcinoma. Our patient is also a smoker and is an alcoholic, which consumes half a bottle of gin every day since 30 years old, which is more than the recommended intake of alcohol in a day. For our objective features, patient upon physical examination, patient is conscious, coherent, oriented, and not in distress. His vital signs, his BP and pulse rate is normal. Respiratory rate is high, and patient has low-grade fever. For the BMI, patient is within the normal range. Patient has pale palpebral conjunctivae and also has ecteric sclerae. Patient also showed signs of uh, palmar erythema, spider angioma, which are stigmata of cirrhosis. Patient also has a slightly distended abdomen. The liver span is 14 cm, which is above the normal value. Patient showed negative signs for fluid waves, bruit, and shifting dullness, which means that patient does not have ascites. Patient is also negative for pedal edema, and upon direct rectal examination, and for the direct rectal examination, patient is unremarkable po.
Janine, you have to emphasize the which you left out, character of the hepatomegaly. Just
Yes po, Doc.
mention.
Okay po, Doc. For the liver po, Doc, liver is also tender and nodular po.
Okay, next.
So our differentials will be based on conditions that present as mass lesions of the liver. So our differentials will be hepatocellular carcinoma, cholangiocarcinoma, metastatic tumors, hemangioma, adenoma, focal nodular hyperplasia, cysts, abscesses, and hepatobiliary tuberculosis. So for hepatocellular carcinoma, it usually presents as a tender nodular hepatomegaly like in our patient. And it would represent 90% of the primary liver cancers. It also presents as abdominal pain, weight loss, jaundice, cirrhosis, and liver tenderness. So we are considering this diagnosis of the the main risk factor is cirrhosis and associated chronic liver damage caused by inflammation and fibrosis. In our patient is known to have a high daily alcohol intake, and our patient also has history of viral hepatitis, and our patient is a smoker. Additionally, uh, our patient has uh, our patient has family history of uh, has, has a family history of a relative
Yan,
dying of
Ian. You are giving us already information that should be given by the group on NCC.
Ay,
So just present
sorry
to
po.
us the generalities as far as approach to a liver mass is concerned. Do not go into the specifics of the disease. Okay.
So sorry po, Doc, nag-choppy po. I did not understand you po.
I said do not go into the specifics of the disease because those specifics will be discussed by the individual group. So what you should tell us would be just a general approach to a patient who presents with liver mass on ultrasound.
Ah, okay po. So for cholangiocarcinoma, it also represents the 10 to 20% of the primary liver cancers. This will seldom produce symptoms uh, until the tumor is advanced, but it will also present with symptoms similar to those of hepatocellular carcinoma. And for metastatic tumors, it is more common than the primary malignancies. However, in uh, our patient presented with a solitary tumor in the right lobe. In metastatic tumors, it would mostly present uh, as liver metastasis
Oh,
that has
Ian,
involved a both.
can I see your next slide?
Ito po.
Can you go back? Go back on the first slide. Okay. Let me just give you a guide, no? What type of tumor was seen on the ultrasound?
Solid po,
Okay,
Doc. Solid
solid
nodular.
tumor. All right. So if it's a solid tumor, what will be your consideration? So you mentioned it could be a malignant tumor, right?
Yes po, Doc.
Okay, and then it could be benign. And as seen here, what would be the more common benign tumor?
The more common benign tumor po, Doc, would be hemangioma.
Okay,
However, in
and then because we're talking of solid, could it be an abscess?
yes po, Doc, because in our patient presented with history of fever po, mild jaundice, low-grade fever, and
Okay, and then
abdominal pain.
all right. So then you go to the next slide. So among those, go to the next slide. Okay, so among those listed, go ahead.
So among our differential diagnoses, we have considered hepatocellular carcinoma, abscesses, and hepatobiliary tuberculosis based on the clinical findings of our patient.
Good morning, everyone. Let us now proceed on how to approach our patient. I'll present two algorithms. First is for non-cirrhotic liver, and the other one is for the cirrhotic liver. First, the initial diagnostic modality that we use is ultrasound. The ultrasound can classify if the mass is cystic, solid, or a possible abscess, which is a complex mass. Please take note that in both cirrhotic and non-cirrhotic liver, ultrasound is always the initial diagnostic modality of choice. Let us now focus on solid lesions. If the solid lesion is suspected for a hemangioma, it can be confirmed by dynamic MRI. On the other hand, if we are not suspicious for hemangioma, but a metastatic malignancy is suspected, then a biopsy should be considered. Lastly, if we suspect focal nodular hyperplasia or adenoma, we perform,
Joshua,
yes po, Doc.
I think in the box under metastasis, CT or MRI is also a diagnostic procedure before you do biopsy.
Yes po, Doc. Sorry po.
Okay, next.
Na-overlook po. So, if we are suspecting for FNH or adenoma, then we perform MRI with hepatobiliary phase. Let us now proceed on a cirrhotic liver. Again, ultrasound. And if we are suspicious for hepatocellular carcinoma and the mass is smaller than 1 centimeter, we do interval imaging at 3 to 6 months. But if the mass is greater than 1 centimeter, we shall perform dynamic CT or MRI. But if the vascular enhancement pattern is not typical of hepatocellular carcinoma, then we should perform our diagnosis by performing a biopsy. So to wrap it up, first, we do ultrasound, and if we suspect hepatocellular carcinoma, then that's the time when we perform dynamic CT or MRI. And if the results are typical, then we treat the patient. But if it is not typical, then we perform biopsy. Thank you.
Okay. Proceed.
Good morning po. So the first differential diagnosis that we considered is hepatocellular carcinoma. So liver cancer accounts for 7% of all cancers. There is highest incidence rates in on Asia and sub-Saharan Africa. Hepatocellular carcinoma has a strong male predominance, and its incidence is found to be increasing with age. So the figure on the right is lifted from Harrison's, and it only shows that liver and bile duct cancer rank first in terms of increasing mortality for both sexes. Up to this date, incidence and mortality rates of HCC have been increasing steadily. So in our country, the table on the left shows that liver is ranked on as the fourth leading site of cancer for both sexes combined in the year 2015, second among males and sixth among females. Same for the figure shown on the right, liver is included in the top 10 leading cancer site among Filipinos. So this is the overview of the factors that causes hepatocellular carcinoma. So liver cirrhosis is the most common cause of hepatocellular carcinoma that is usually caused by chronic hepatitis B, chronic hepatitis C, excessive alcohol intake, and non-alcoholic liver fatty disease, while aflatoxin causes a direct liver damage.
That's
So for
non-alcoholic
chronic
fatty liver, hindi liver fatty disease, ha? Fatty liver disease. Okay.
okay pa. So for chronic hepatitis B, it is endemic in Southeast Asia and Africa. Point 1 of individuals with chronic HBV without cirrhosis develop HCC due to the carcinogenic effect of the virus. Its mechanism are thought to be caused by chronic inflammation that is caused by host immune responses during the infection, and this can lead to fibrosis and cirrhosis. And another mechanism would be the integration of the viral genome into the host DNA. For chronic hepatitis C, it is more common in Western countries. Unlike HBV, HCV is least likely to develop HCC in the absence of cirrhosis. Chronic HCV infection causes persistent inflammation that leads to the development of hepatocellular carcinoma. Other factors for the development of cirrhosis are NAFLD and excessive alcohol intake. This was already discussed a while ago. As we all know, excessive alcohol intake can cause liver damage that will eventually lead to hepatocellular carcinoma. Aflatoxin is a mycotoxin that contaminates stable food crops. It is the most potent hepatocarcinogen, causing direct damage and mutation of P53 gene, therefore destroying the liver. So, in summary, cirrhosis, whatever the etiology is considered the major risk factor for developing HCC. Chronic hepatitis B, chronic hepatitis C, excessive alcohol intake, and NAFLD are the most common factors that causes cirrhosis, eventually progressing to HCC. However, in some patients, etiologic factors such as HBV, NAFLD, and aflatoxin may directly progress to HCC even without the occurrence of cirrhosis.
Morning, doctors. Good morning, classmates. Hello.
Yes,
Ay, narinig po ba ako?
yes, we can hear you.
Sorry,
So,
yes, yes, Erica.
good morning. I'm Jean. I'll be discussing the clinical features of hepatocellular carcinoma. So, hepatocellular carcinoma is a condition that is, as mentioned earlier, is characterized by a tender nodular hepatomegaly. So, as you can see here, the most common and frequently first symptom is right hypochondrial or epigastric pain. And the symptoms listed here, they are the most common symptoms to be found in patients with HCC. So it's abdominal pain and weight loss, both of which we can see in our patient. Other than that, the most common sign would be hepatomegaly, as mentioned earlier, was found in our patient. Other other symptoms that other signs that we can find on PE, the arterial bruit over the tumor, which is not pathognomonic but is useful in diagnosis. And the physical evidence of cirrhosis, such as spider angioma, palmar erythema, which are seen in our patient, and signs of decompensation, such as ascites, jaundice, and pitting edema. Other some of the deleterious effects of HCC may be due to paraneoplastic manifestations, although each paraneoplastic manifestation is rare or uncommon in the population of patients with HCC. So listed here, the first two are the most common to be seen. Uh, the most common that occurs in less than 10% of patients would be polycythemia, and in less than 5 patients would be type B hypoglycemia. So these pictures are just simply illustrations of what we may see in patients with HCC. So as I mentioned earlier, palmar erythema, spider angioma, these were seen on PE of the patient. And in more severe cases, we can see caput medusae or sometimes parotid enlargement along with other manifestations. Yes po, Doc.
Yes, Dr. Chan.
Uh, Erica, these are not the pathognomonic features of HCC. These
Ah,
are
yes
the
po.
physical examination findings that you will see in a patient who has cirrhosis or portal hypertension.
Ah, yes po, Doc. Apo.
So please don't say that this is due to HCC.
I'm sorry po, Doc.
This is not
Okay,
due to HCC, yes.
yeah, okay. It has to be clarified, Erica. Again, no, you
Yes
might
po.
mislead your classmates. These are manifestations of like palmar erythema, spider angioma, parotid enlargement,
Ah, yes po, Doc.
manifestations of cirrhosis, caput
Yes,
medusae, manifestation of portal hypertension.
hypertension. Yes po, Doc.
Okay.
Because these features po of cirrhosis and portal hypertension may also manifest in hepatocellular carcinoma, but it is not necessarily po yung like main clinical features. It's just the features because of the cirrhosis and the decompensation or portal hypertension also.
Okay, next.
Hello po.
Yeah, just to emphasize, you look at Dr. Wong's message. Not all HCCs can occur in patients. Not HCC can occur in patients without cirrhosis. Therefore, those stigmata of cirrhosis may not be present in patients with HCC. So it
Ah,
has to
yes.
be clarified. All
Okay
right?
po. Okay po.
Okay. Next, Jessica.
Hello po. Good morning. Rinig po ba ako?
Go
Yeah,
ahead.
we
Go
can.
ahead.
Rinig
Go ahead, go ahead.
Yeah.
Okay, so the surveillance testing is to identify HCC in its early stages when it is still amenable to treatment. So who should be regularly screened for HCC? So number one, we have cirrhotic patients, Child-Pugh stage A or B. Because HCC arises from a background of cirrhosis in 80% of cases worldwide, we must screen cirrhotic patients. The Child-Pugh score is a system used to determine the prognosis of chronic liver disease and cirrhosis. So why stage A or B? Because stages A and B are still amenable to treatment, and our goal is to reduce mortality. Number two, cirrhotic patients with a Child-Pugh stage C awaiting liver transplantation. Child-Pugh stage C cirrhosis is advanced cirrhosis, no longer eligible for HCC-related treatments. Thus, they are no longer recommended for surveillance, except if they are awaiting liver transplantation, because this can affect their priority on the waiting list. How about non-cirrhotic patients? We screen non-cirrhotic patients with chronic HBV infection because these patients are at risk of developing HCC even in the absence of cirrhosis. Therefore, we screen chronic HBV carriers if they are Asian aged more than 40 years, if they are African aged more than 20 years, or if they have a family history of HCC. Lastly, those with HCV-related advanced fibrosis or bridging fibrosis, who can also develop HCC even in the absence of cirrhosis. How do we do surveillance? We do surveillance by doing ultrasound on the liver.
Yes, Dr. Chan.
Jessica, what about patients with chronic hepatitis B? Don't they deserve to be also undergoing surveillance because of the risk for HCC?
Doc, I'm sorry, chronic hepatitis, ano po?
Chronic hepatitis B.
B? Oh, yes po. Yes po. No,
So,
non-cirrhotic chronic hepatitis B po.
so it's not in your list.
It's in number 3, Dr. Chan.
Carriers. These are carriers. Non-cirrhotic hepatitis B, the carriers. With active hepatitis. Okay, go ahead.
Okay po. So, current
My
guidelines recommend...
my concern though, Jessica, is this part of your diagnosis? You're
Doc,
reporting on diagnosis, right?
opo. Okay, skip ko na po ba, Doc?
Kasi surveillance ito eh, hindi ito
Opo.
diagnosis.
Opo, in-include ko lang po for completion.
Uh, Sige, just go through the right side. Next slide na. Next slide.
Okay. Doc, mention ko lang po yung alpha-fetoprotein. It's a tumor biomarker for HCC with 60% sensitivity but high false positive results. And another limitation is that only a small proportion of early tumors present with abnormal AFP serum levels. So we do not recommend this for surveillance. Okay. So, unlike most solid cancers, the diagnosis of HCC...
Sorry. Jessica,
Yes po.
can you go back one slide? You mentioned that AFP is not recommended for surveillance, you said?
Yes po, Doc. But I mean, recommended po, pero the benefits of it is not that great. Therefore, we can do surveillance with or without AFP.
Yeah, well, that is based on the American guidelines, but our very own Asia Pacific guidelines say that you should still check for AFP. Because
Okay po, Doc.
although you said that a normal AFP may not help you, but an abnormal AFP will lead you to do additional tests in order to get the diagnosis. So it still helps. So
Okay.
kasama ang AFP surveillance.
Okay po.
Okay. The reason why for the class, no, the reason why we did not include surveillance for this particular case is that when you say surveillance, you have a patient who is at risk to develop HCC, but there's no symptom, no finding. So in this particular patient, there is already a liver mass. Therefore, your task is to diagnose what that liver mass is.
Okay
All
po,
right?
Doc.
So you go
Opo.
direct to diagnosis.
Okay. So unlike most solid cancers, the diagnosis of HCC can be established based on non-invasive imaging without confirmation of biopsy in cases of patients with cirrhosis. So what do we do if we are screening a patient and we find a nodule or mass? We refer to this guideline from the European Association for the Study of the Liver. This is also what is found in Harrison. So nodules less than 1 cm in size are unlikely to be HCC and are difficult to diagnose reliably because of their small size. And as long as the patient is in regular surveillance, they may be followed safely. Even if they grow to 2 cm, complete response to therapy is almost always achievable. Therefore, we repeat ultrasound at 3 to 4 months and look for changes in character of lesion or growth. If the lesion is more than 1 cm, we can employ the use of 4-phase CT or dynamic contrast enhanced MRI. We look for the HCC radiologic hallmark in 2 imaging modalities if the lesion is 1 to 2 cm, and in just 1 imaging modality if the lesion is more than 2 cm. This radiologic hallmark will be discussed in the next slides. It is important to point out that HCC radiologic hallmark only occurs in a small proportion of patients with small tumors. Thus, biopsy or tissue biomarkers will be required in most instances. Also, when masses reach beyond 2 cm, there are increased levels of treatment failure. Therefore, as much as possible, we want to diagnose HCC before it reaches that size. Also, biopsy is required in non-cirrhotic livers, and for those cases with inconclusive or atypical imaging appearance in cirrhotic livers. So what does HCC look like on imaging? The first picture here is an ultrasound of the liver where we can see a hypoechoic mass compared to the surrounding liver parenchyma. So if this is less than 1 cm, repeat ultrasound at 3 to 4 months and observe for changes in growth or character. If this is 1 to 2 cm, we should do both CT and MRI. And if this is more than 2 cm, we do either CT or MRI, just one. First, what are the phases in a 4-phase CT scan? We have non-contrast, late arterial phase taken 35 seconds after contrast, portal venous phase taken 60 to 80 seconds after contrast, and delayed phase taken 6 to 10 minutes after contrast. So next, let's orient ourselves. This is posterior, this is anterior, this is right, this is left, this is the vertebra, this is the aorta, this is the IVC, and this is the liver. Okay, so what do we see here in the non-contrast phase? The mass is actually not visible. What do we see in the arterial phase? Wait lang.
Dr. Chan, Jessica is actually writing. Can you see the blue circle
Yeah.
there?
Okay.
So what do we see in the arterial phase? We see enhancement of the mass during the arterial phase. Why? Because HCC is a hypervascularized tumor and receives blood from the hepatic artery. Therefore, it's receiving its blood supply during the hepatic phase and the arterial phase and becoming visible. We can also see that the aorta is enhanced during the arterial phase. So in the portal venous phase, the rest of the liver parenchyma is being supplied by the portal vein and becoming more hyperdense. And there is progressive washout of contrast material out of the HCC, making it hypodense in comparison to the liver parenchyma. And in the delayed equilibrium phase, the contrast is moving away from the liver and there is continued washout of HCC. This is the radiologic hallmark of HCC. Tumor hyperenhancement during the arterial phase with washout during portal venous and delayed phases. Here is a simplified version of this. Here is an MRI, and it also shows the same thing. We have hyperenhancement during arterial phase and progressive washout during the venous phase and delayed phases.
Okay, I hope the class very clearly got the explanation for the characteristic diagnostic findings of HCC in your triphasic CT and MRI. No? As we mentioned, if those findings are present, they are diagnostic for HCC. When we say diagnostic, we can proceed to treatment without doing biopsy. Okay, proceed.
Okay,
Dr.
so
Wong, you want to say something? Dr. Wong?
I just wanted to emphasize that emphasize the meaning of the washout. So as I've put in the chat, uh, after the initial hyperdensity or hyperintensity phase, it will now become hypodense or hypointense relative. You always compare it with the normal liver parenchyma, relative to the normal liver parenchyma. And that is what we call washout.
Okay. Go ahead, Jessica.
Okay, so the most accepted staging system is the Barcelona Clinic Liver Cancer Classification. In HCC, three parameters are relevant for defining treatment strategy: tumor status, cancer-related symptoms, and liver dysfunction. So the BCLC staging captures all three variables. The prognosis of chronic liver disease is commonly assessed using the Child-Pugh classification, which uses 5 clinical measures: serum bilirubin, serum albumin, prothrombin time, ascites severity, and hepatic encephalopathy grade. Child-Pugh's A reflects well-preserved liver function, Child's B moderate liver function, and Child C is severe liver dysfunction. Performance status is assessed by Eastern Cooperative Oncology Group, or ECOG performance scale. Its ECOG 1 to 2 is considered a sign of advanced stage. Um, okay. Patients with liver-only neoplastic symptoms, no symptoms, and with mild to moderate liver dysfunction can be classified as very early, stage 0, or early stage A, or intermediate stage B stages, depending upon tumor size and number. So very early HCC BCLC0 is defined by single tumors less than 2 cm and includes either single tumors or a maximum of 3 nodules of less than 3 cm in diameter. Intermediate stage is defined by all other liver-only tumors. Conversely, HCC is considered at advanced stages BCC, when patients present cancer-related symptoms or tumors with macrovascular invasion of any type, including branch hepatic or portal pain, lymph node involvement, or extrahepatic spread. Finally, end-stage disease BCLCD is considered in cases of several impairment of quality of life, cancer-related symptoms, or severe liver dysfunction.
Okay, Jessica, can you go back one slide? Okay, this is also just to emphasize to the class that by doing your CT, it is not only the characteristic finding that you look at to diagnose HCC, but also to look at portal vein invasion or invasion to the other vascular areas surrounding the tumor, because presence of invasion to those vascular uh, uh, to the portal vein, for example, or vascular structures would mean an advanced stage of your HCC. Okay, very good. Next reporter.
Hello. Oh,
Okay,
hello.
go ahead.
Okay. So staging systems are important in individualizing the treatment plan for patients because they are used to stratify the patients according to prognostic factors and outcome and to allocate the best available therapies. There are mainly three types of treatment based on the stages that were presented. For very early stage and early stage, we utilize the curative treatments, namely ablation, resection, and liver transplantation. While for intermediate stage and advanced stage, we utilize the palliative treatments, namely chemoembolization and systemic therapies. while for terminal stage, we only use the best supportive care. So for the curative treatments, resection is the first-line option for non-cirrhotic patients at early-stage HCC with solitary tumors. This is in contrast to liver transplantation, which is the first treatment of choice for cirrhotic patients provided that they fulfill the Milan criteria. The Milan criteria is universally used as the basis for transplant eligibility, and adherence to it yields good post-transplant survival. Liver transplantation is useful as it simultaneously cures the tumor and the underlying cirrhosis and has a low risk of recurrence. However, there are important limitations such as cost and donor availability and the need for lifelong suppression. Ablation is used for small tumors, specifically those less than 3 cm that are not amenable to resection or transplantation. Radiofrequency ablation or RFA is recommended as the primary ablative technique and it works by inducing coagulative necrosis. In contrast to percutaneous ethanol injection, RFA is more effective in response rate and time to recurrence. Chemoembolization is the most widely used primary treatment for unresectable
Okay.
HCC
Very
worldwide.
good. Just for additional information of the group, because you mentioned that ablation therapy is used for small tumors, 3 centimeters or less. Dr. Wong is doing ablation therapy and has a very good number to share to us. Maybe Stephen, you can share to the group uh, just a short summary of your results, no, in doing ablation therapy for HCC, specifically in
Yeah,
terms of selection, patient selection.
yeah, but it's correct that the your book says that the ideal size will be 3 centimeter or less because the probability of ablating the whole tumor is highest in those. But you can actually burn bigger tumors up to 7 centimeters. But then you have to discuss this with your patient because the probability of incomplete ablation is also higher, the bigger the size of the tumor is. Okay, so in general, your book is still correct because they're looking at all, everyone who's doing the ablation, so that the ideal size is still 3 centimeter or less. But in cases where, uh, for example, a solitary tumor that is 5 centimeter in size, who is not a candidate for surgery, then RFA will still be a good option because tumors 5 to 7 centimeters can still be burned.
Okay, Dr.
Okay.
Wong, Mary
Thank
Claire,
you po
can you
daw.
proceed?
Okay po. For again for chemoembolization, it's the most widely used primary treatment for unresectable HCC worldwide and the first line indication for patients with intermediate BCLCB stage. As you can see in the picture, chemotherapy is administered via the hepatic artery. For systemic therapies, it is important to note which drugs are first line and second line. For first-line drugs, the most important is sorafenib, which is the standard of care systemic therapy for HCC. Its recommended daily dose is 800 milligrams taken for 6 months. While for second-line drugs, we have regorafenib, cabozantinib, and ramucirumab. So for prognosis, an estimate of the prognosis is made by looking at the liver function, not the severity of the liver disease, which is why we use the Child-Pugh score, which reflects this. For Child-Pugh A, it is considered as well-compensated disease, while, however, this is seldomly seen in patients since the patients consult the doctor when they are symptomatic, which indicates advanced disease already. While for child PUB, it is considered to have a significant functional compromise with a median life expectancy approximately 3 years. For child PUC, with a total score of 10 to 15, it is considered to be decompensated disease with a median life expectancy of approximately 1 year. So for our patient, we think that the liver mass is most likely HCC, mainly because of the patient's age, chronicity of pain, presence of weight loss, a history of acute viral hepatitis, and a first
Mary
degree
Claire, can I
family
cut you
history
there?
of.
Sorry, Dr. Wong, you raised your hand.
Mary Claire,
Yes po, Doc.
just to make sure that you understand this figure. It's about because you've already in our BGDs we've already looked at gastric CA, for example, colonic CA as gastrointestinal malignancy. You notice that we always use just the tumor characteristic, the TNM. But what do you notice about HCC in terms of staging the disease? What is different in HCC compared to the other tumors, gastrointestinal tumors? Look at
I
your
think
Uh,
here
BCLC
you
staging.
mentioned that
Diba may
already.
tumor characteristic tayo?
Uh, she mentioned in your first statement, you mentioned that. Mary Claire, are you still
So,
with us?
yung sa liver function po,
okay. What about the liver function?
rapid po yung progression ng disease. So, yung liver function niya, mainly mabilis po yung affectation.
No, in terms of looking at your figure, makikita mo, diba, there are, in terms of the staging, you use the tumor characteristics, right? Meron ka dong size of whether it's single or multinodular, but you also notice that there's, you mentioned liver function, right? And ECOG. What is ECOG?
Albert,
Okay, let me just simplify what Stephen is trying to say. In most GI cancers, you use the TNM classification. But in liver cancer, you're actually treating two diseases. And therefore, it's not just the liver cancer, but the liver function, which is due to the cirrhosis of the patient. Okay? Yun lang yun, very clear. So, ang classification mo includes the tumor characteristic as well as the liver function, which is Child's Pugh classification. Plus, of course,
Okay po.
the ECOG classification. Okay?
Okay
So
po, Doc. Thank you
let's
po.
Mary
diagnose
Claire.
the patient.
Okay. Okay. Mary Claire, I told you your first statement when you presented this slide is to that effect. Diba? Ano yung statement mo? It's really what Dr. Ismael mentioned, that
Okay
in
po.
prognosticating liver cancer, you said you don't just look at the tumor, but the liver function. I heard
Apo.
you say that. Okay. So it's just being put into the right context. Okay. So why HCC? You always start with the problem. What is the problem presented by this patient?
For the patient, there is a solid tumor that is
Okay. So you start
nodular.
with that. Oh, sige. Go ahead. Why
There's a
HCC?
solid tumor that is nodular. There is hepatic tenderness and hepatomegaly on a background of cirrhosis.
Okay. We accept that. All right. Let's go to the next group. Thank you. Very good.
Thank you po, Doc.
Okay, so next we move on to liver abscess, which is defined as the encapsulated collection of superfluous material within the liver parenchyma resulting from bacterial, fungal, or parasitic microorganisms. These abscesses can be solitary or multiple, affecting one lobe or both, and traditionally it has been useful to think of liver abscesses in two broad categories: those of bacterial origin, otherwise known as pyogenic liver abscess, or those of cytic origin, primarily caused by Entamoeba histolytica, leading to amoebic liver abscess. So we move on to pyogenic liver abscess, which is the most common type of visceral abscess, accounting for 48% of visceral abscesses and 13% of intra-abdominal abscesses. Its annual incidence rate is 2.3 cases per 100,000 population. It is higher among males than females, especially those with underlying biliary tract disease. In Taiwan, there is a reported higher rate with 17.6 cases per 100,000. This is a study suggests that this is due to underlying renal disease and malignancy that increase the incidence. In Asian countries, Klebsiella pneumoniae is the leading cause, whereas in Central Europe, pyogenic liver abscess is typically caused by E. coli, Streptococcus, or Staphylococcus. The next type is amoebic liver abscess, which is the most common extraintestinal manifestation of amoebiasis. It is caused by Entamoeba histolytica, and this disease is encountered in 3 to 9% of the cases of amoebiasis, according to a study done by Perez in 2006. It is more, according to Harrison's, this age is age and gender dependent, with males 30 to 60 years old most commonly infected at a rate 10 to 12 times higher than women in the same age group. This male predominance may be explained by a study in mice where activation of natural killer T cell producing interferon gamma, which is important liver abscess control, is influenced by the inhibiting effect of testosterone. In the US, young Hispanic adults are the most commonly affected by this disease, and this disease is found in endemic regions of India, Africa, Mexico, Southeast Asia, Central and South America. In the Philippines, it is also found mainly in northern Luzon, Marinduque, Mindoro, Samar, Panay, and Palawan. So, the following are the populations at risk for having amoebic liver abscess. They are those who live and travel to endemic countries, as mentioned before. They are patients who are institutionalized at mental health facilities, homosexual males who have sex with males secondary to oral anal sex, and immunosuppressed individuals such as those with HIV, malnourished with hypoalbuminemia, alcoholics, chronic infections, post-traumatic splenectomy, and steroid use.
Hello po, good morning.
Good morning. Continue.
Yes po. So liver abscess, as mentioned earlier, is basically divided into two big groups, which are pyogenic and amoebic. So pyogenic, as explained earlier, is due to bacteria, and also it is worth noting that these are usually due to polymicrobial infections. So mentioned here are the possible causes of the pyogenic infections, such as Klebsiella pneumoniae. It is worth noting that it can cause liver abscess in the absence of an underlying hepatobiliary disease, which is very common. And also, biliary tract infections are usually caused by aerobic, enteric gram-negative aerobic bacilli and enterococci, such as your E. coli and also your Enterococcus fecalis. And also other sites such as pelvic and intraperitoneal sources, and also via hematogenous route. Also, our patients can also be affected from fungal causes such as from Candida species, and also from tuberculous causes such as Mycobacterium tuberculosis. And also the next big type of liver abscess is due to amoebic abscess, which is mostly due to Entamoeba histolytica. Next. Okay, so I'm just gonna explain this very briefly. So Entamoeba histolytica is ingested, and the cysts are converted into trophozoites in the colon, and the trophozoites then invade the mesenteric vessels. And onto the portal circulation, it will then go to your right lobe of the liver, which is the more predisposed area of the liver for amoebic abscess due to its drainage from the superior mesenteric vessels. And also, amoebic abscess can be ruptured and may cause empyema and bronchohepatic fistula, pericarditis, and peritonitis. This is the general signs and symptoms of your liver abscess, which can be attributed to both pyogenic and amoebic. So most common is fever of unknown origin according to Harrison's. And if you have fever of unknown origin, you must have a high suspicion of possible liver abscess. And also in 50% of the patients, hepatomegaly, right upper quadrant tenderness, or jaundice may manifest. There are also non-specific signs and symptoms such as chills, anorexia, weight loss, nausea, and vomiting. So according to your Schlesinger, there was a table that this is the table from Schlesinger, which just shows the most distinguishing feature between the two. So for pyogenic liver abscess are often multiple, as opposed to the amoebic, which is usually solitary and they're located in the right lobe near the diaphragm, as I explained earlier, due to the superior mesenteric vein. And also, pyogenic can be more subacute rather than acute, and amoebic is more of an acute onset. Jaundice may manifest on both, but is not really that common, but can be mild for pyogenic and moderate for amoebic. It is also worth noting that for diagnosis, you should really do US ultrasound, CT scan, and also serology to rule out um, because the because your imaging findings are not very conclusive to differentiate pyogenic from amoebic. Okay, and also for serology is very specific and sensitive for amoebic, so you can see the amoebic abscess, and also you can also perform your um, drainage, and you can see the for your pyogenic there are more neutrophils in the fluid, and for amoebic there will be the characteristic is like an anchovy sauce appearance of the fluid.
Okay, are you done with diagnosis, Ian?
Yes po.
Have you mentioned chest X-ray? Is there
Yes,
any use?
yes po. Apo. For the chest X-ray po, it will just manifest mostly of right hemidiaphragm elevation due to the hepatomegaly, and also might also show right pleural effusion or findings of bacillar atelectasis po.
So if you have an elevation, yes, Dr. Chan. Dr.
What
Chan?
about a plain film of the abdomen or a scout film of the abdomen? Yes, what about a plain film of the abdomen? Can it help in the
Um,
diagnosis of an abscess?
for the plain film po, Doc, I'm not maybe we can do CT scan na lang po instead of the plain films or ultrasound
No,
din
I
po.
Ian, the question is, if you do a plain film of the abdomen, what finding will you look for if you are entertaining abscess? Will there be a finding that would highly suggest that there is an abscess in the liver?
Um, will there be hypoechoic findings po, Doc?
No,
Ay,
hypoechoicity is or
sa ultrasound
uh,
po.
yeah,
You
Opo.
may find an air fluid level in the right upper quadrant area.
Air fluid level po, Doc.
because
Yes.
of
Because of
Okay.
hepatomegaly po.
no
Bec-
air. Bakit may air?
Because of meron pong abscess po, meron pong nag-accumulate po.
Bakit nga? Dr. D, are you raising your hand?
Yeah. I just want to add that in X-ray, not only the lungs are should be evaluated, but also the heart, especially if there's an enlarged heart, which may probably, especially for those who are non-hypertensive, it may suggest pericardial involvement, not only
Yes
the
po.
right?
Yes po, Doc. Thank you po.
So you have gas there if the etiology are gas-forming bacteria. Therefore, there will be gas formation and you can have an
Yes po.
fluid level in that abscess. There's a question by Dr.
Po, Doc.
Velasco. Why would patients with liver abscess present with jaundice? You mentioned it may not be seen in all patients, but they can occur.
Yung sa
Why would
jaundice po,
there be
Doc?
jaundice? Huh?
Yung sa jaundice po,
Yes, yes.
if there is a biliary tract disease po, Doc, that can be a cause of the abscess.
Okay. If there's biliary obstruction, what else?
Or there may be presence of multiple abscess po. Or meron na pong complications, liver complications po.
If there's multiple abscess, what does it do to the liver parenchyma? Why would there be jaundice? So the presence of an abscess means you have a
Damage po to the
space-defined
liver parenchyma, which is
you have a
magre-release po ng bilirubin.
space-defined lesion, ah.
Ano po?
Dr. Velasco? Dr. Velasco? Can you help Sian? Okay, so in patients with liver abscess, there could be i- there is a space occupying lesion which could
Yes
in
po.
effect cause some degree of cholestasis. That's one. And then of course the inflammation itself can induce liver injury, and that
Okay po.
can produce some degree of liver cell necrosis, no? Some degree
Yes
of
po.
hepatitis.
Okay po.
Okay,
Yes, Doc.
next. Are you the next treatment?
Yeah. Yes, good morning, Podok. So most of what Zedi and Tarola mentioned was for diagnosis, but I will just expound quickly on what he said. So history and physical exam are important to help diagnose liver abscess. So age, gender, and medical history can help differentiate between pyogenic versus amoebic abscess. The presence of abdominal pain, fever, malaise, nausea, vomiting, weight loss, anorexia, and recent travel history are also important. Um, However, it's important to note that symptoms are usually non-specific and is only suggestive towards amoebic versus pyogenic. However, on physical exam, the most common for pyogenic is fever, while for amoebic is hepatomegaly with pain upon palpation, which can be felt over the liver, below the ribs, and in between the intercostal spaces. And then jaundice, decreased blood sounds, and sepsis may be also present in complicated cases of liver abscess. For laboratory studies, for CBC and liver function studies, I put in parentheses here pyogenic and amoebic. However, it's important to note that it's not specific and only suggestive for the two between the two diseases. So for CBC, we should take note if there's any anemia and neutrophilic leukocytosis. And then for liver function studies, hypoalbuminemia, elevated alkaline phosphatase, and elevated transaminase and bilirubin should be taken note of. Um, as for ELISA test, it is widely used to diagnose amoebic liver abscess, which has detects. Yes, doc.
Yes, Dr.
So,
Wong.
Carlo, because you've put in open close parentheses, pyogenic, amoebic. So, are you telling us that if you see that, for example, hypoalbuminemia, if you see that, that's already pyogenic?
No, doc. It is only suggestive for pyogenic from what I've read.
So, it can be found also in patients with amoebic.
Yes, doc.
Okay. Can you explain how alkaline phosphatase? Because book it says that the most consistent abnormal laboratory result is an elevated alkaline phos. So why do you think the alkaline phos is elevated in patients with abscess?
I would, if I were to guess, Doc, I would believe it's due to the liver damage caused by the abscess.
Liver damage?
What
When does
particular
alkaline phos
element?
become increased ba?
I'm sorry, Doc,
What
can you
causes
repeat
an
the question?
elevation? What causes elevation in alkaline phosphatase?
Yes, Doc, it was
Discussed in passing in the last BGD. What is the cause? What does it
cholestasis, Doc.
imply?
Cholestasis, Doc.
Cholestasis?
Yes.
Due
Yes,
to
Doc.
So when you
cholestasis,
have
why would there be
system,
cholestasis?
whether it's intrahepatic or extrahepatic. Yeah, so why will there be cholestasis in abscess?
Because of the obstruction, po, Doc.
Due to
Why will there be obstruction? What's the obstruction?
Extra.
Is it extrahepatic or intrahepatic? Yun na lang. Two choices.
Intrahepatic, Doc.
Intrahepatic. So if you have a mass there, if you have an abscess, there's actually a mass effect in your liver. So that mass will impinge, compress on your intrahepatic bile ducts, and that can lead to an increase in the alkaline phos. So given that scenario, do you think alkaline phos elevation is specific for an abscess?
No, po,
If you
Doc.
have for example, sige, ganitong scenario, you have a patient, there's a mass, and then you check the alkaline phos, mataas ang alkaline phos. Does that mean that the patient has an abscess?
No, Doc.
Because your book says that's the most consistent abnormal result.
No, Doc.
No,
It's not diagnostic for abscess. Only suggestive.
because can a patient with, for example, hepatocellular carcinoma also have
Yes,
an
Doc.
elevated alkaline phos?
Yes, Doc.
Okay,
Anything
very
that
good.
causes
That's because
obstruction.
of the yes.
Yes,
Okay.
Doc.
Okay, so just to clarify for the group, any space occupying lesion in the liver, whether it's hemangioma or cyst or HCC or abscess, can elevate your alkaline phosphatase. Okay, can we go to the next slide,
Yes, Doc.
Carlo?
So
Okay.
for imaging, the imaging studies are most reliable, as Zedi Hentarola has explained. Ultrasonography is most preferable, and it should show up as a round oval mass with well-defined margins and hypoechoic. And CT scan can be accompanied with ultrasonography, which should appear as a low density with smooth margins with contrast-enhancing peripheral rim. However, it cannot distinguish between pyogenic from amoebic abscess.
Okay, Carlo, can you go back?
Yes, Doc.
I think what you need to emphasize is the ultrasound picture. If you look at the ultrasound picture in contrast to the solid tumor that was presented uh, by the previous group, what is characteristic in this ultrasound picture for you to think of an abscess?
Doc, I would.
You have a white area there and
Yes,
a
Doc.
black
This
area
white
there.
area here, this white area here, it is what's it called? Maybe edema, Doc.
No. What do you call what is the characteristic mass lesion in abscess seen in ultrasound? If in HCC you call it solid tumor, how about in ultrasound? Or you look at Dr. Chan's message.
Complex mass, Doc.
Diba? It's a complex mass. Okay, so you have a solid component there, the white area, and a liquid component, the black area. So there's a complex mass. Dr. Dalupang, sinagot ko na rin. Sorry. All right, I will go to the next.
And then we can perform percutaneous needle aspiration, which is both diagnostic and therapeutic, which allows for recovery of material for microbiologic and pathologic evaluation. And it's usually known for unknown etiology or if the abscess becomes too big.
Okay, let's go to the next treatment.
Good morning, doctors. Good morning, classmates. So for the treatment of liver abscess, we have two parts. You have your medical management and your drainage. So first for the medical management. So for pyogenic abscess, the drugs used for empirical therapy are the same ones used in your intra-abdominal sepsis and secondary bacterial peritonitis. And then prior to administering these antibiotics, you should obtain your blood cultures and the diagnostic aspirates of the abscess. And the cases treated without definitive drainage generally require longer courses of antibiotic therapy. Using medical management alone is seen to be effective in some cases, usually those with smaller abscesses. Then moving on, for patients with candida liver abscess, you usually use your amphotericin B. However, your therapy with fluconazole alone may be used if the organism aspirated is seen to be susceptible. Then for your amoebic liver abscess, you can give metronidazole plus a luminal agent, which is iodoquinol, because patients usually have a concomitant infection in the GI tract. Moving on to drainage, so your first method is your percutaneous drainage. You can see it here, a pigtail catheter used under ultrasound guidance. So indications for percutaneous drainage include ruling out a pyogenic abscess, the lack of clinical response to antibiotics in 3 to 5 days, when there's a threat of imminent rupture, and to prevent the rupture of left lobe abscesses into the pericardium. And next, we have your surgical drainage. This is preferred over your percutaneous drainage in cases where there are multiple sizable abscesses. Abscess contents that tend to plug the catheter, when there's associated disease that already requires surgery, when there's yeast present, when there's communication with an untreated obstructed biliary tree, and a lack of clinical response to your percutaneous drainage in 4 to 7 days. So to wrap this part up, we think that the solid tumor seen on ultrasound is a liver abscess due to the following presentations in the patient. Abscess may initially be solid before your liquefaction. The patient, oh yes, doc.
Sorry, I did not catch it, but did you discuss when drainage for amoebic liver abscess?
You go back one slide.
Yes, in the other slide.
Here po.
You discuss it. I did not see it.
So to continue the statement earlier, we consider it an abscess because abscesses may initially present as solid masses before they liquefy. The patient presents with fever, weight loss, tender hepatomegaly, and jaundice, which are also manifestations of your liver abscess.
Okay, very good.
Thank you po.
Next group.
Good morning po.
Good morning.
So for the third disease, hepatobiliary TB, let's start first with the incidence and epidemiology. This disease is a very rare extrapulmonary manifestation TB infection. Abdominal TB in general presents as 3.5% only of all extrapulmonary TB cases. This is a US data. And hepatobiliary TB specifically presents as less than 1% of all TB cases. This is because of the low oxygen tension present in the liver and in the biliary system, because Mycobacterium tuberculosis is an aerobic mycobacteria, therefore it thrives best at areas of high oxygen tension, and that's why this particular form is rare. It may occur primarily or it may occur as part of a disseminated disease in the context of a pulmonary or GI TB. Now, if we move on to the local data, this was taken from a study done by Dr. Alvarez at UST Hospital. It's very interesting to that hepatobiliary TB is actually very common among Filipinos, but it's not common among, for example, the Chinese living here in the Philippines. And also, it's not common in other Asian countries that have high rates of TB, but they actually have very low rates of hepatobiliary TB. And so, you can't hear me po ba, Doc?
Maybe just increase your audio a little bit, although I can hear you, Joanna. Mel, I can hear Joanna. Maybe just increase a little bit.
Yes po, Doc. Is
Okay,
now
go
better
ahead.
po? So because of this reason, Dr. Alvarez was able to conclude that there's a racial predisposition of Filipinos specifically to the development of hepatobiliary TB. Now, if we look on to the age and sex distribution, we see that it's more common in males. There's a 2 times prevalence in males as opposed to females. And the age of incidence, the peak incidence is from 11 years old to 50 years old, especially the ones with the 21 to 30-year-old age range. Moving on to classifications, there's 3 types. The first is miliary TB. This is the most common form, and actually it accounts for 50 to 80% of all deaths from tuberculosis. It's part of a generalized disease, so this is usually from a hematogenous spread, as I'll discuss in the pathogenesis later. And what we see is we see these clustered miliary tubercles. So the term miliary TB is because of these millet seeds. So because on what we see is they look like these tiny millet seeds that are scattered throughout an organ. In this case, we have the picture of a lung, but it's the same thing in the liver. The signs and symptoms are non-specific because this is a generalized disease. And then the second form or the second classification is a granulomatous disease, also known as tuberculous hepatitis. In this case, the small miliary foci, those small millet cells looking things, actually enlarge and come together or they confluence together to form these nodular involvement, as you can see in the picture. So the signs and symptoms of this particular classification present with fever of unknown origin. They may also present as mild jaundice with or without hepatomegaly. And on liver biopsy, you see caseating granuloma. As the term implies, it's a granulomatous disease. For the third form, we've got localized hepatic tuberculosis, also known as a tuberculous pseudotumor. It occurs in 20% of all cases of disseminated TB, and it may be secondary to reactivation of a previous or latent TB infection. Now, the signs and symptoms of this particular classification is referable to the hepatobiliary tract, and it's specifically classified into 2. There's the first one is the focal or nodular one that refers to a TB abscess, and this abscess can be either a solitary or a multiple mass, and it's also known as a tuberculoma. And the second form is a tubular form, and this is the disease of intrahepatic ducts, so it's also known as TB cholangitis. And so because it's a disease of intrahepatic ducts, it can present with symptoms of obstructive jaundice, such as because of the inflammation of the ductal epithelium that would prevent bile from moving out and from flowing out, and that's why we have symptoms of obstructive jaundice. Moving on to the pathogenesis, Harrison's listed 3. So the first mechanism is a swallowing of sputum with direct seeding. This is in the context of patients with a pulmonary TB infection. So the sputum here are filled and teeming with mycobacteria, and they can swallow that, and that would lead to direct seeding of the liver. The second mechanism is hematogenous spread. This happens in the context of either an active or an inactive TB infection in the lungs, and from the lungs, they are able to gain access to the liver via the hepatic artery. And the third one is ingestion of infected milk. This is most common in developing countries, such as here in the Philippines. So when there's infected milk that's infected from cows with Mycobacterium bovis, this is another form of a mycobacteria. It's a non-tuberculous mycobacteria. This leads to primary intestinal TB. And what happens is the mycobacterium, once they enter the GI tract, they are able to go and migrate here into the mesenteric veins, as indicated by my pointer, and then they can go up into the portal vein and eventually reach the liver. Now, there's another form of pathogenesis which was not listed in Harrison's, but which was stated by Dr. Alvarez, which is the lymphatogenous spread. So these mycobacteria can actually initially seed into the lymphs first, and then these lymph nodes near the portal vein in the portal tract, when they rupture, that would lead to seeding of these mycobacteria into the liver. Finally, we've got the clinical features that we see in hepatobiliary TB. Abdominal pain, it has an asterisk there because according to Dr. Alvarez, it's the most important clinical feature and it usually presents as a right upper quadrant pain. Hepatomegaly is the most common finding on the other hand, and it's important to note in hepatomegaly secondary to hepatobiliary TB that the hepatomegaly here presents as a tender and nodular form of hepatomegaly. And as discussed previously, this is also the same presentation we see in hepatocellular carcinoma. We can also see the features of splenomegaly, intestinal wall involvement, obstructive jaundice, as I've explained earlier, and also non-specific signs such as fever and weight loss. Yun lang po.
So, good morning po, doctors.
Okay. Very good, Joanna. Excellent.
Okay.
Thank you, Doc. Uy, Doc Velasco, hindi po yun. Hindi ko po siya kamag-anak. Hindi ko yun kilala, Doc.
All right. Go ahead,
Okay.
Stephen.
So, good morning, doctors. So, I will be discussing about the diagnosis of hepatobiliary TB. So, we rely primarily on imaging and biopsy for the diagnosis of hepatobiliary. We must note that blood workups such as transaminases may be useful to rule in a liver pathology. However, they are non-specific for hepatobiliary TB. So first, we have here a plain radiograph or a scout film of the abdomen, so we can appreciate liver calcifications over here. And this is seen on scout films of 50% of cases. As discussed earlier, primary TB of the liver is very rare. So among cases with hepatobiliary TB, they also show a concomitant abnormal chest X-ray demonstrating pulmonary TB. Next, we have ultrasound. It shows multiple complex masses and hypoechoic lesions with no significant walls. We must note that it is difficult to distinguish from carcinomas. Next, we have the CT scan. So it appears as in the form of multiple small foci. Kasi here, for example, here, it's small po talaga to. Here. And also, we can appreciate necrosis as a non-growing low-density lesion with a slightly formed peripheral rim. Over here, Doc.
Stephen,
Yes, Doc.
sorry,
Yes, Doc.
sorry. The ones you're pointing out, calcifications are white on CT scan.
Yes, po, Doc. These
It's
are
not
abscesses po, Doc.
hypodense. Hindi yan calcification.
These are microabscesses po, Doc.
Go ahead.
To continue.
Okay, go ahead, go ahead.
We could use both ultrasound and CT scan for guiding biopsies po, since biopsy would be the definitive diagnosis of hepatobiliary TB. So as we can appreciate here, this is a photomicrograph of the liver cacheating granuloma, which is diagnostic of TB. So this is the cacheating granuloma surrounded by a ring of lymphocytes. And in cases where there are non-cacheating granulomas, the biopsy specimen could be subjected to AFB staining or culture of TB when there is a high index of suspicion that it is truly hepatobiliary TB. And that's all po, Doc.
Okay, next.
So, good morning to doctors. For the treatment of hepatobiliary TB, the treatment for hepatobiliary TB does not differ from that of the pulmonary TB. Conventional antituberculous therapy involves the use of at least 4 drugs to remain the cornerstone of treatment. So, the duration of the
Dana?
Yes, Doc.
Choppy yung audio mo. Can you fix it a little bit? Maybe choppy.
Hello. Hello? Hello? Still choppy? Hello, Doc?
Okay, better.
Okay na po. Okay.
Yes, yes.
So, the duration of the WHO recommendation for extrapulmonary TB is generally only given for 6 months. So isoniazid, rifampicin, pyrazinamide, and ethambutol are given for the initial 2 months of intensive therapy. Then isoniazid and rifampicin are given for the next 4 months for the continuation phase. However, according to the study of Doc Alvarez, 1 year of treatment of anti-TB drugs has shown good clinical response with disappearance of abdominal pain and fever, reduction of size of the liver, and increased appetite and weight gain. So, in conclusion, the only difference between the WHO and Doc Alvarez study is the duration of treatment po. So the study of Doc Alvarez was also supported in a study done by Chowdhury in 2014. Recommendations in this study suggest also prolongation of treatment for hepatobiliary TB. For the initial phase is extended to 4 months, while the continuation phase is extended for 6 months. So patients who develop hepatotoxicity from isoniazid, rifampicin, and pyrazinamide are treated with ethambutol, streptomycin, and possibly another drug. The American Thoracic Society recommended more vigilant serum ALT monitoring in patients who consume alcohol, in the case of our patient, and those who take concomitant hepatotoxic drugs. Also, according to Doc Alvarez, the development of PCR assays for identification of Mycobacterium tuberculosis can be used to gauge response to treatment. However, in Harrison's, it is stated that the response to treatment is evaluated by using culture and smear microscopy. So that's it po, Doc. And then
Okay.
for
Last statement.
Okay po. So we think that the solitary tumor seen on ultrasound is tuberculous in nature due to the patient's history of TB and, as Joe mentioned, manifestations of abdominal pain, hepatomegaly, icteric sclera, fever, and weight loss. That's it
All
po,
right.
Doc.
Okay, Joshua, can we hear you,
Hello.
Joshua?
Hello again. So our group decided that the solid tumor seen on the ultrasound of this patient is most likely due to hepatocellular carcinoma because on physical exam, the patient presented with tender nodular hepatomegaly, and in addition to that, the patient also presented with weight loss, strong family history, and with a background of cirrhosis. With that said, thank you very much and have a good day.
All right. So do we have questions from the facilitators? Are we okay?
Okay.
Dr. Dalupang, yes?
Joshua, what about another PE finding for HCC? Any other PE finding that will tell you that it's HCC or hepatoma?
Joshua,
May not,
Doc,
it
yung
may be
ano po,
present or not present.
yung Doc, the stigmata of liver cirrhosis po.
No, that will tell you that your patient is cirrhotic and it may be a risk factor for HCC. It may be present or absent in a patient with hepatoma. In this patient, it is actually absent. So, what PE finding is that? It's brewy. No, brewy.
Right.
All right. Okay, so we'd like to thank Group 6 for your presentation. Very good. And now we will proceed to your SGD.